Hello and welcome to today's show. Today we're going to talk more about living wills. Specifically, we're going to examine in more detail the treatment options that present themselves in a living will document. Additionally, we're going to talk about organ donation. I am Jeff Rehmeyer. I'm an attorney and president at the CGA law firm. Historically, my practice has involved real estate, estate planning, and business. In recent years, I've been focusing more on estate planning to include planning for young adults. On today's show, we have back again our favorite doctor, Dr. Michael Spangler. Welcome, Doc.
Glad to be back. Thank you so much.
By way of short background, Dr. Spangler is the Vice President of Medical Affairs at UPMC Pinnacle Memorial Hospital, having had a terrific career so far, starting with Memorial and continuing through. Dr. Spangler has a Bachelor of Science from Ursinus College, a Doctor of Osteopathic Medicine from Lake Erie College of Osteopathic Medicine, and a Master's of Healthcare Administration from Maryville University. So the doctor is experienced and educated and here to help us learn more. So previously, Doctor, we did talk about living wills, which include healthcare treatment instructions in an end-of-life scenario. Could you take a few minutes just to recap when a living will comes into play, and then we'll dive deeper into some of those options in the living will?
Absolutely. Just to go and recap what we talked about before, what the common misconception that's out there is as soon as somebody brings in a living will document, that the minute they step into the hospital, that living will takes control. It's really not. It's if the patient is end stage in their either their disease process or their medical management of an acute condition. So the big thing is, just because a living will says, hey, you know what, I don't want to be intubated, I don't want to be shocked, does not mean that the minute that you hit the emergency department, that all bets are off and we won't do what we need to get you better. It's really all about stabilization. Once you're stabilized, if we're at a condition that is futile, at that point in time, that living will document takes control. If you're unable to make decisions on your own behalf, that living will document or your durable power of attorney end up taking that role as well. So like I said, I think it's vitally important that we have these discussions early. We don't wait until that nth hour happens to start saying, oh, I wish I would have had a durable power of attorney, or I wish I would have done a living will. Do that while we're cognitively good, while we can make those decisions on our own behalf, because not only does it benefit the care of us as we enter those situations, but it really looks out for our family members and that power of attorney to make decisions and understand what our wishes are. Because so many times people enter the hospital and all of a sudden now we have a huge life decision to make. And if a patient is on the ventilator or we have them in a medically induced coma, they can't tell the family members what they want. If we get that scenario ahead of time by filling out these forms and really kind of taking the time and have these discussions, we can make it so much easier on our loved ones. Because I've been involved in way too many times where we as physicians, we have to tell the patients and the caregivers the facts of what's going on. We can't enter that world of, hey, if I were you, this is what I would do type of situations. And we see that a lot, and people look to us and we can state the facts and we can say, hey, you know what, things really do look futile. But unless those conversations are had ahead of time, it's really difficult as a family member to really kind of take it to that next level.
So two key points that I heard. One is having those discussions in advance about what you want to have happen to you under certain circumstances. Interestingly, doctor, during other interviews with others on these similar topics, the discussion has come up time and time again. Have the discussions, have the hard talks. Now, you had also referenced the second point, which is the living will doesn't come into place unless medical care is futile. And how is that futility?
Lost you there for a sec, Jeff. There you go.
We're back.
I see you now.
Okay.
Commercial break.
Unintended commercial break. Thank you for technology. So to go back to my question, how is a determination made that medical care is futile?
Yeah, typically that decision is very difficult. There's a couple ways that gets done. First and foremost is in the acute care setting. We don't really decide futile care until the patient's stabilized, which means you have a blood pressure, you have a temperature, everything's kind of in a stable situation. Because let's be honest, if you come into the emergency department and those things are out of whack and we can't get them better, we can't participate in futile care because the person doesn't do well long term. True futile care is when we've done everything that we can from a medical standpoint and say that we have now stabilized the patient, but we do not see them advancing or getting back to a previous state of health. That's when we start really having that discussion, ethical discussions on what really does futile care look like. And the futile care we talk about is kind of interesting because it dovetails with what those things are really nicely in that living will document, because not everything is necessarily futile. For instance, if someone's blood count drops real low when they get really symptomatic from it, meaning you get a patient who is, let's say you have end stage cancer, right? And we're still trying some chemo, still trying some ways to kind of treat that patient. We know that the cancer drugs we use make numbers drop, make people require blood transfusions. That's not futile care. That's extending a meaningful life in that situation. Futile care are those things where, now, if I was finding myself where somebody is in an end stage cancer situation where we're giving somebody a couple units of blood every week and it really just numbers do not improve, and then next thing you know, we have other problems that happen where the kidneys start to fail, or we start talking about, okay, are we going to need dialysis in addition to it? As we start taking that end stage patient and start adding on these call it multi-system organ issues, when the kidneys are involved, the blood's involved, the liver's involved, all these things, we start saying, okay, now we're entering a futile situation. Now, one of the other things is typically one doctor themselves did not identify that the patient's futile. Typically, that's a group of physicians or a team of providers that actually decide that. Whether it's two different providers at bedside. We talked a little bit about the wonders of telemedicine. We can do some really cool things with telemedicine, especially in the world of COVID when it was really bad. But it's so important that even a physician can get a little bit of tunnel vision when you're dealing with a patient day in and day out for a week, 2 weeks in a row, to not step back and say, okay, is there anything else that I'm not doing? And if I keep on doing the same thing over and over again and the person isn't getting better, that's when we need our colleagues, when we need the team to kind of step up and say, hey, did we have this discussion to start really kind of setting the stage of this difficult situation that's coming?
Thank you. So looking at the check boxes on the living will, there's opportunities to check that you do or do not want things like heart-lung resuscitation or a mechanical ventilator or dialysis. When considering those and doing a living will, what sort of thoughts should go behind that?
Yeah, I think first we got to look at medical background. For instance, you have a patient who has a large lung tumor that's growing in their lungs, that we tried chemotherapy, we tried radiation to shrink the thing, and we continue to fight a battle that we're just not winning. In that situation, what happens is you have a person essentially is breathing with only really one lung, or in cases where somebody's been, let's say, a smoker for a long period of time, even less than that, because their lungs don't function the way they need to. If you put that patient on a ventilator, there is a high likelihood that you will not be able to take that tube out again to have the patient breathe on their own again, depending on what the underlying issue is. Now, let's say that person comes in, it's a relatively small lung tumor, and they develop a pneumonia. Okay. That patient, you put a tube in, you treat the pneumonia, you pull the tube out, and the patient breathes with no problem. Let's change that scenario. Let's say you have a large lung tumor with bad lung disease, let's say on the opposite side. Now you put that tube in the patient's throat, and like I said, that person really was breathing poorly to start with. It could be their COPD that had advanced. It could be that tumor now has grown to the point where that lung, there's not enough functioning lung to actually allow that patient to breathe. In those situations, it is a very, very difficult discussion to talk about removing that tube. There's a lot of misnomers out there in medicine where they say, "Oh, I'm going to pull the plug today." Unless you're really in that situation, it's really tough to really appreciate what that term means and what that feels like as a family member. We talk about withdrawal and care is how we talk about it, but in those situations where, let's say your loved one with the lung mass has gone through a year's worth of chemotherapy treatments. Let's say on a good day, they're unable to do those things that really make life meaningful for them. They can't walk around a grocery store. They can't get themselves ready in the morning and do their normal, what we call ADLs, that brush their teeth, comb their hair. Weird to say from a bald doctor, but do those things that some people really hold dear to them. Once they've lost that, the question is, even in those circumstances where, hey, you know what, maybe this is reversible, or maybe it's not. There's a lot of people that say the worst thing in the world that could possibly happen to me is I die while I'm on a ventilator, while I'm unable to talk or see or participate with my family members in those last hours of my life. So that's really where that comes into play. Now, I do know that there are some people that, let's say I'm 60 years old and I had a family member who was in their 90s who actually ended up dying on a ventilator. There are some times when emotions rather than fact get in the way of filling out one of those documents. They start saying, "Oh, I don't want that to happen to me, so I don't ever want to be placed on a ventilator." Well, that's the wrong time to have that discussion, because as we talked about earlier, the living will is really reserved for those end of life decisions, those chronic medical conditions that aren't getting better. So the 51-year-old that thinks that hey, you know what, I never want to be placed on a ventilator, they got a lot of things going on. Let's say they had a sudden heart attack. Well, there's a lot of things in medicine we can do to have a 51-year-old get better from their heart attack. Okay. That may be putting on the ventilator. That may be pushing on the chest. That may be a series of medications or things that go on over the course of several days till the patient gets better to the point where their tube is removed. Those are reversible causes. Those are things that we can do. But like I said, we need to be careful not to mix up the medical reasons for doing these living will checkoffs from the emotional side that says, I just don't want that to happen to me. Again, perfect situation to have your durable power of attorney that understands what you mean in those circumstances, right? So it's not that, hey, I never want to be placed on a ventilator. No, it's that if I'm in a phase of my life where I will not get better by either placing that tube or staying on that tube, and I have to stay on a ventilator for the rest of my life to let this machine breathe for me, then I don't want to continue that way. Please be empowered that tube gets removed according to my living will in those certain situations. So, like I said, there's two different sides, and we see it all the time. Now, one of the other things that we need to bear in mind is there are times, even without a living will, that we decide to terminally extubate people or terminally pull out a breathing tube. Things like the patient's had a massive stroke and just will never regain the ability to breathe on their own or to even function on their own. Those type of situations, we need to have that durable power of attorney, or those uncomfortable situations. I can remember situations where you have unfortunate where a 40-year-old ends up having a sudden bleed into their brain that they don't get better with. Those are things that, yes, technically, if they would have done a living will ahead of time, that it would have been enacted in those situations, but it's kind of an awkward phase. And typically, even we as medical professionals will go back to that durable power of attorney and say, hey, let's just talk through this. Let's discuss why that living will does say so much at this point in time. So it's a different discussion depending on the situation.
So when I have clients look at the living will, they typically do agree that if they're in the end of life scenario or permanently unconscious or vegetative, don't prolong their death. And then they typically further indicate that in those circumstances, they don't want things like heart lung resuscitation, mechanical ventilator, dialysis, surgery. Am I correct in thinking that they say they don't want those things because at that point the medical care is futile and it really cannot help them?
100%. I agree with that completely. The two other things that you mentioned in there. Number one is true resuscitation, that whole act of CPR and pushing on someone's chest. One of the things that we don't think about is when we have a loved one or even whatever with that gets very weak and malnourished, and what we term in medicine as cachexia, where somebody becomes very, very frail as they get further along in the disease process. You get someone my size doing CPR, appropriate CPR on them. I'm going to break most of the ribs that are in the anterior part of their chest, and their ability to recover from that, their ability to even breathe with broken ribs is very poor. So, like I said, those discussions about, hey, you know what? I don't think you'd even survive, even if we get your heart beating. I'm not sure you'd survive otherwise. So that's one of those things. We have a lot of those discussions because I mean, it's interesting as we look and how medicine has evolved, even in the period of time that I've practiced, where we used to have all the family members go to a certain area while resuscitation is going on, and then we bring them back with an unsuccessful resuscitation or after they come back. Now we offer family members to actually be there during that resuscitation process. And I can't tell you how many times that family members have looked at me and said, why are we doing this? Well, you said you wanted us to do this. You said you wanted us to do everything well, I didn't recognize that that's what you were going to do. Well, like I said, that's the true good and bad about doing chest compressions. The other thing is dialysis. Dialysis is a very interesting lifestyle. In the acute phase, where kidneys fail, we can get kidneys waking back up again with a couple dialysis treatments in a row and the kidneys start to get better, or they needed acute dialysis in the hospital. We discharge them. They need it 3 times a day. And over time, they can slowly wean those off and people don't require dialysis anymore. However, one thing that a lot of people don't recognize is those people that are on chronic dialysis or end-stage kidney disease, frequently they're on that machine 3 times a week, 3+ hours a day, and it really cuts into people's life, right? I mean, it's a whole new pattern. It's 6 hours that you're attached to a machine a week, maybe even longer. It's cramps. It's things that go on where you may have to go to the hospital if there's a problem during dialysis. Again, I'm not saying that even young people need to consider that, because in the world of organ donation, which we're going to talk about in a little while, in the world of organ donation, there's amazing things we can do with kidneys and get people off of kidney dialysis. But in those people that we were talking about earlier, the elderly patient with the metastatic cancers or the like, having them go 3 times a week to sit for 3 hours at a time, hooked up to machine, just getting there can be a problem, much less tolerating the actual dialysis process itself. So again, and in the really sick patients in our ICU, it's all of these things that we go into that discussion of. And typically that's the big 3. Do you want CPR? Do you want me to put a tube in your throat to breathe for you? And if your kidneys fail, do you want to be placed on kidney dialysis? Those are really the big 3 that actually make a lot of difference here in the hospital.
So as a practical matter, when I'm completing a living will, let's say I do it for myself, is there a reason that I would check yes, that I do want some of these things if I'm in fact in an end-stage medical condition? Why would I say yes to anything if I'm going to die or if I'm permanently unconscious or vegetative?
That's a great question. I would put in a for instance in there. let's say the only problem that you have is end stage renal disease. Okay. And let's say you develop a lung cancer. Okay. There for the longest time, we've been talking about, hey, you know what? We're going to continue to do dialysis. And at some point in time, you may receive a kidney. So life would be good. So that's one of those situations where you might say, no, I don't want, I'm sorry, I do want dialysis, but I don't want to be intubated. I don't want to be, I don't want to have CPR. However, you then enter that world of, okay, now I got something else. And you may actually end up going back to that document and saying, okay, things have changed. I don't want to do dialysis anymore. All of a sudden, dialysis gets no. Or in the situation where, got to think about some of these other ones. Because like I said, most people choose when care gets futile, no for all three of those statements. I got to be honest, the ones that we say yes for end up being things like antibiotics. Sometimes on these forms, it says blood transfusions. Those things, I mean, the idea of, hey, you know what, antibiotics can possibly reverse the state in which I'm in. If it does, great. If it doesn't, I completely understand. So those are more the ones that I think we have to have that yes, no discussion of. Most of the time, like I said, people end up choosing the no for those first three.
So if I go back big picture, when I'm meeting with my clients, if they don't have any particular medical issues at the time, and they're doing a living will that may or may not come into play years down the road, they would say, yes, if I'm in the end stage medical condition or permanently unconscious or vegetative, do not prolong my death. And they would further emphasize that by saying, I do not want things like CPR, like a mechanical ventilator, and those things.
Absolutely.
However, if you have a living will and your medical condition changes, and there's some treatment that's helping you deal with that condition, but you worsen, you may want to revisit those selections in the living will so you're not prohibiting a treatment that might be somehow helpful based on your particular condition at the time. And that's kind of an overlay to the living will. So it's almost as if we get back to, not only do you need to have the discussions, which you said and others have said, but you need to keep an eye on your status and potentially update your documents, which is actually a theme that comes up in a lot of my discussions. Just because you said it today doesn't mean you forget it forever. You think about where you're at. And I believe a further evolution of this would be the do not resuscitate order, or the DNR, which is a slightly different document that basically is a full-on overlay that just says, based on what I know today, if I would otherwise require resuscitation, don't give it to me because I don't want to be resuscitated.
Absolutely. Okay. And there's another document out there as you have elderly loved ones that may be living in nursing homes or the like, the pulsed form, which is a pink form that can be attached to the patient's chart that basically functions as their DNR order as they're going in and out of the hospital. Because we as the hospital even attach that to them as we're going back to that nursing facility.
Okay. So big picture before we segue to organ donation, have the discussions in advance with your loved ones, with your medical professionals if it's appropriate, make decisions and document them, and then be mindful of the decisions you made and if you need to adapt and adjust moving forward.
Yep. Just because you say one thing today doesn't mean you can't go revisit that even a week from now or a month from now or several years from now. Because let's be honest, the only thing constant in life is change. And we need to revisit that time.
Okay. So. And then from your perspective, and you've given us some for instances, and I would say this is true for me too, you've seen people that have failed to put the documents in place or update them, and that does create challenges or harm for themselves or emotional pain and loss for their family members.
Correct. Yeah. And I think you can't really appreciate that until you're on that opposite side and how difficult it is to make those decisions, especially those patients where when you look at them and they're on a ventilator and it looks like everything's fine. And it looks like, you know what, all they need to do is remove that tube and dad's going to walk around. It's a hard decision to make. And like I said, we as individuals can make that decision so much easier on our family and loved ones. Because who wants to place that burden on anybody within our family?
Mm-hmm.
We would never want that to happen.
Nope, I agree. Well, thank you for your insight on that, Doctor. Let's continue to extract some more insight from you, and let's talk about organ donation. So the Advanced Healthcare Directive, which includes that healthcare power of attorney in the living will, also has a checkbox for a person to consent or not to consent to donating organs and tissues at the time of death for the purpose of transplant medical study or education. So if I have a client that has interest in doing that, and I really have a few, most clients are fine with it, although I do have some who are older or have medical conditions and basically say, nobody's going to want my 80-year-old organs, so no. Can you talk to us a lot? Can you talk to us a little bit about why people may or may not want to donate? Is it true if your organs are 80 years old, nobody wants them? How do you analyze that question, or how would you deal with that comment?
Yeah. There's a couple different sides I take from that. Number one, I'm going to address the I'm too old for organ donation right off the bat. It's surprising what all is available for organ donation. Cornea, skin, those kind of things. I know some 80-year-olds say nobody would want my skin, but like I said, in a person who's a badly burned victim or something like that, we use a lot of things. Corneas are the most common things in the older patients to take. It's not taking their eyes; it's taking that outer layer of the eye itself. So the answer is, you're never too old for organ donation. You might actually be surprised what is usable and what's not usable. That's number one. Number two, like I said, I love the fact that this information is on a driver's license. I think that's a fantastic thing. I myself am an organ donor. There's no doubt about that. I get to see the lives that it impacts, even though something catastrophic could happen. For instance, I'm in a terrible car accident on my way home today. The number of lives that I can impact during that is absolutely amazing. Between heart, lungs, liver, pancreas, we have so many things right now that people are out there on these transplant lists right now waiting for, that are living very difficult lives. Go back to the dialysis question. The nice thing about kidneys, we got 2 of them. We can impact 2 lives with one unfortunate life lost. It makes 100% turnaround difference for some of these patients. We're also combining things, heart lung transplants, we're kidney pancreas transplants. I mean, there's these combo transplants. There's actually partial liver transplants. The cool thing about the liver is the liver can regenerate to some degree, so you don't have to take the whole organ. You can take a piece of that organ and let it live and kind of go forward. But the big question that everybody has is, okay, well, if I'm an organ donor, they're not going to take something from me before they make that medical determination that I'm irreversible, or that I'm futile care at that point in time. And the answer is no. We work with a organ transplant team that is absolutely amazing. What they do is when we have somebody that we know is in organ donation and they have gotten to that futile point, let's put in a patient into that. Let's say someone 45 years old ends up with a spontaneous bleed into their head, and we know that from testing that person essentially is, I'll say, brain dead, for lack of a better term. We do tests, we identify that. We then call the organ donation spot and say, hey, you know what? We have a patient that is a known organ donor, and is to that point where we need to have the discussion. They'll come in and talk to your durable power of attorney, your family members, talk them through the entire process and what this looks like. Surprisingly enough, the hardest thing to do in those circumstances is really determining what the time of death is. Because what happens is we keep a patient alive until we can get the people who come, and it's a kind of a rough term, to harvest the organs at that point in time. Sometimes they have to fly in from, like for UPMC, we fly people in from out in Western Pennsylvania. They come in ready to go, but we have to keep a person alive during that point in time. The other thing that's interesting is we need to continue to draw labs on that patient, because we need to make sure that in that period of time when we're waiting from the determination that yes, we will donate our organs until we donate them, we need to make sure that those organs continue to be healthy, right? We need to make sure that if we're transplanting a liver, that shock or some other issue doesn't take over until we can actually harvest that organ. Make sure that heart is as good as we want it to be. Maybe sometimes we do some imaging on it just to make sure that it's okay. But I got to be honest, one of the most difficult challenges that I've had in the past is somebody that's an organ donor and hasn't discussed it with their significant others at home. It's just like we talk about selecting the power of attorney the right way. When you make the determination that you want to be an organ donor, you need to let everybody know, including your durable power of attorney, of course, but let your family know. I had a situation in the past where I had somebody that was an organ donor. Now, I didn't know them before they came into the hospital. We had the proof and everything else that was there, but the family came in and said, we do not want this to occur. You fall into a real sticky wicket at that point in time. I got to be honest. I mean, you know what the patient wanted, but at that same time, legally, ethically, what do you do? And sometimes the process in the particular situation that I'm talking about, between getting an ethics committee in, sometimes even getting lawyers involved because of these things, it ends up taking a lot of time. And unfortunately, in the situation that I remember, we couldn't donate the organs any longer. So we as healthcare providers look back on it and say, did I do my best? We know what the patient wanted. And to me, I failed that patient because they wanted to give that ability for life for someone else. And we didn't do it. So I think that's a really tricky part in making sure that your loved ones and everybody else recognize what you want. Now, there are some people that donate my body to science, where you want your body to go to like a medical school to train doctors and those kind of things. That's a little bit different than true organ donation. That involves some other documents that are out there, and you have to have an agreement and all those kind of things. And I got to be honest, as a doctor myself, I appreciate the people that donated for us, because the amount of information that you learn as a physician is absolutely amazing when people do that. The ultimate sacrifice, but it's not one of those things where it's a heartless act. We get clergy in, we have everybody available to really have peace in the decision that we're making. And like I said, depending on where the organs go and what the family wants to do, I got to be honest, sometimes the letters that come back and say, hey, I was impacted by a heart from an unfortunate situation. I mean, it brings a whole new meaning to what organ donation is all about. And like I said, my hat's off to everybody who really says yes to organ donation. Like I said, I don't think I could be a doctor without saying yes to organ donation, to be quite honest, because I've seen the effects of successful organ donation. But in this situation where we are dying from whatever that reason is, we don't have a whole lot of use for it on the great beyond. And like I said, I think we can look out for our fellow man in that situation and really kind of make a difference. And I got to be honest, some of those family members in that ultimate time of grief where their loved one is dying, especially in situations where it's a very young person that's dying, knowing that they're giving the chance of life to someone else is a powerful emotion, and a way that they can find some kind of silver lining in a devastating situation.
Wow. So I thank you for all that. To back into a few questions or comments I have. So the Advanced Healthcare Directive is one place where you can indicate that you're an organ donor.
Yep.
You can also do it through the state on your driver's license. Yep. Am I correct in thinking that either or both of those are ways that you signal a medical facility like UPMC that your organs are available for donation?
Absolutely. Absolutely.
And then virtually anybody probably has organs of value for some purposes. For my 80-year-old client that says everything's worn out, maybe it's the cornea, maybe it's something else. Right. So then it becomes a personal decision for you when you do these documents. Do you want it to give of your body when you no longer need it? Right. And many say yes, some say no. Obviously, a very personal decision.
Absolutely. Now, you have to understand, too, that you don't have to have it on your driver's license or on that document that we're talking about to be an organ donor. We have that discussion with every person that passes. Hey, would you be willing to donate? Mm-hmm. And we have that with a family member. It's, again, talk about a tough time for a decision. Mm-hmm. A lot of the times we get trushed off pretty quick in those situations, but we still give that opportunity to say, hey, you know what? Is there any opportunity here for organ donation?
And to your point earlier about the discussions, if you as a person feel strongly about it, having it on your driver's license or having it in this document makes it a much easier discussion for your family because they know that's what you want. And my sense is, and correct me if I'm wrong, that for a family member to make that decision about a dying loved one is much harder to do at the time because you often get into the more, I'll say that the more graphic or more real life impacts of what it means. If you're taking somebody's skin, it's hard to make a decision to a loved one who's dying and say, go ahead and take it, even though it's good. But if that loved one has said in advance on a driver's license, an advanced healthcare directive in a discussion, it's important to me. I'd like to help somebody if I'm going to die. And you're right. What that does is creates a better decision at the moment. And it creates that emotion you talked about. And I do have friends who've lost loved ones, including young men. And I can sense from them the inspiration of the gift that young child, that young man gave through organ donation through his death.
Absolutely. Absolutely. Something that whole feeling of, I know some people say, well, the heart is surviving somewhere in someone else. And like I said, I have had people who have met who those organs go into and establish a relationship with them. Mm-hmm. You see things on the news and media sometimes of these situations where somebody gets to meet that person that they've affected that life, and what a powerful situation that actually ends up being.
Amazing. Anything else you'd like to add on organ donation today, Doc?
I don't think so, other than the fact that, like I said, I think everybody should everybody that's watching this, I think you take some time, maybe even today, to think about what it means to be an organ donor. Like I said, I see the benefits of it. I fail to see the detriments of it, but that's just my own personal opinion. But I think a little self-reflection to say, what can I do? And if you do decide that, it's time to update the documents. It's time to get that on your driver's license and make a statement. And like I said, have the discussion with your family members as well. There's a lot of people out there. If you look at these lists for organ donation, the lists go on and on and on and on, that people that end up dying on that list because an organ never became available for them. Mm-hmm. And it's an opportunity to really kind of make a difference. So please consider.
Outstanding. Well, thank you again for being here with me, Dr. Spangler. Your insight, your experience, your approach, all very valuable to me, very valuable to those who are watching. And for those who will watch this, you're going to come back one more time. And we're going to get to cognitive decline, which is a topic that a few people have asked about. So I think today's takeaways on that living will are actively have those discussions, consider your circumstances, do the documents at the time, keep an eye on yourself moving forward, update if you need to. And of course, lots of benefits with organ donation, a decision you can make today that your loved ones can carry out and you can impact the lives of others.
Absolutely.
All right. Thank you, doctor. Have a terrific day.
You too. Thank you for your time.